All right, let's continue. Any questions from the first half? Everyone feel comfortable with some of those basic pharmacokinetic principles and how we can apply those to possibly your patients? Okay, so we're going to talk now about some specific populations we're dealing with, primarily geriatrics and then pediatrics. You say geriatrics, who am I referring to? Yes, old people. How about more specifically? Greater than 65. I'm glad you didn't say 32. Would be, anywho, right, so we're primarily looking at like 65 and older. We know this is a continually aging population, so we know that the proportion of our patients are going to be considered geriatric are getting bigger every single year. Looking at U.S. population above this age, around 15%, that's only going up. And then with life expectancy getting better and better as we get better medical care, you're going to be treating these patients for longer potentially, right? So the thing to talk about here, we're talking about some physiologic changes that occur with your elderly patients in life a little bit later on. But one of the first things you have to do is kind of assess your patients. So I'm going to focus on a couple of things that can kind of help us out from the drug standpoint and when you're assessing your elderly sort of patients here. Basic things you're going to be kind of looking at is that you're kind of looking at functional ability. You're looking at things like, things that assist the patients, whether it be with affording their medications or whether they have anyone to help them take their medications. Because you're going to find that our older people typically more complex or more simple in their medication regimens than say younger people. A lot more complex. You're going to find that they're going to be on 10, 15, 20 drugs in some instances, no problem. Like, these patients can be on just a boatload of drugs, and it's important to kind of figure out, are they even keeping up with all of these? Are all of these necessary? Because a lot of times you run into this issue where patients are seeing multiple specialists, right? So for instance, they have maybe you as their family practice provider, and then they're going to see a cardiologist, they're seeing an endocrinologist, they're seeing an ophthalmologist, and they're all prescribing different drugs. Now, do all those systems communicate together? Do all those providers talk to each other? Usually no, right? So you can have someone be writing a drug, say potentially writing for a drug that is going to fix their hypertension, maybe makes their glaucoma worse, and then now the glaucoma is worse, and now the ophthalmologist is writing for another drug that's maybe making their hypertension worse, and usually you guys being kind of the center point of that, usually being, especially in the family practice realm, are going to be the ones that can kind of catch a lot of that. And this is why it's so important to do a good assessment and good sort of medication reconciliation to kind of figure out what they're on and see what's going on here. Because a lot of times people say, they come in with an issue, usually a side effect from a different drug, and then how do you fix that problem? Well, you think to discontinue that other drug, but a lot of people just add on another drug, right? That causes other side effects. You have to add on another drug. This is the problem. And as much as I like job security, fewer drugs is typically better for patients, as it turns out. And so we can really help with that. Because again, the other problem with multiple specialists is if the cardiologist writes for something, but it's obviously causing a problem with, say, a different disease state, who's likely to want to DC that medication, right? Discontinue that medication. You don't want to touch it, right? Because then you're going to make the cardiologist mad, or something bad happens, and that's on you now. So people oftentimes are very hesitant to discontinue medications that other people have started, and so you can see how these things tend to snowball after a while. But anyway, so again, it's very nice to have a good interdisciplinary team of providers, right? So when I say interdisciplinary team, who are we involving? Thank you, everyone. Yes. Maybe more specifically, what are some members of this interdisciplinary team that you could involve? So obviously the provider, so whether it's a physician or mid-level, who else? Nurses is good, yeah, absolutely, because they're the doing the front line sort of work there. Nurses are critical to include in dealing with your patients. Who else? Pharmacist is good. Yes, you should involve the patient, absolutely. Or in the case of like dealing with like pediatrics, having the parents involved, because guess what? If they don't sign off on something, they're not going to do it, right? Who else? Dietary is really important to include, so like to have our dietitians around, and then any kind of specialists that might be involved in the case. So again, and if you go to like an ICU or go anywhere where there's like rounds going on, typically there's like a whole gaggle of people that are there, and that's good because you want to involve as many people as you can to get different perspectives on things to make sure that you're looking at the whole picture, right? Because me as a pharmacist, guess what I'm thinking of? Thinking of drugs, right? However, the dietitian's probably thinking of their diet. The OT person's thinking about, occupational therapy exercise and things like that. So everyone has a little bit different perspective, and it's important that we collaborate for that. So anyway, so when I talk about activity of daily livings, what does that include? What do you think of that? Can they get up? Can they walk around? Can they shower? Can they make food for themselves? Right? There's varying levels of this with varying complexity. But this is important because as people get older, typically what happens? they get less functional, right? Or potentially if they've had a stroke and they may have a major decrease in the ability for them to perform these activities, or if there are medications that are preventing them from doing some of these. And so you want to assess for these to kind of figure out where the patient's at, what they can do for themselves, or what they may not be able to do for themselves anymore. Additionally, if they can't, who's doing it for them, if anyone. Nutrition is very important here. We can find that a lot of older patients typically have impaired nutrition or poor nutrition in some cases. Some of it could be related to they're just not able to eat very well. Maybe they have kind of poor dentures or maybe ill-fitting dentures. Maybe they have decreased appetite either due to appetite suppressing drugs, or maybe they have depression that maybe is not being treated effectively. And then a lot of medical conditions can also affect this as well. So things like constipation, cancer, dementia, all that can affect that additionally. Maybe lack of financial resources, if maybe they don't have any programs like Meals on Wheels or something that can provide meals to them, that can be an issue. Or if they have a hard time actually getting out to the grocery store, a lot of them might not even be able to make it out of the home in order to get their groceries, right? So that could all limit what their nutritional intake is going to be like. So what I like to do is make sure you're asking a good 24-hour sort of recollection of what kind of foods, drinks, vitamins, supplements, anything like that, any non-drug stuff they've taken in the last 24 hours, including the amount, right? So for instance, you want to tailor it to specific instances. So for instance, if I'm dealing with, someone who is on warfarin, I mentioned that's a blood thinner, and is very dependent on vitamin K intake, right? Remember we said vitamin K is very important for producing what in the liver? Clotting factors, right? So again, that has a direct impact on how that warfarin's working. I'm going to ask them, well, what kind of green leafy vegetables are you getting into? Do you eat kale? Do you eat spinach? How much of it are you eating? How often? If you're thinking about things like drinks, for instance, like, okay, how much alcohol are you drinking? Are they having worsened dementia and perhaps maybe their alcohol is interplaying with some of their drugs? Maybe. Are they drinking grapefruit juice that's causing drug interactions that cause their levels to skyrocket, causing side effects? So these are things you kind of want to ask about. Ask about things like how many meals they're eating, how often, if they're getting any kind of fruits, vegetables, milk, things like that. And again, you can sometimes even tease out certain drug interactions just from basically what their diet is. So for instance, they take their medications right as soon as they eat. Maybe some of those are binding up to one another. The calcium binds up to the drugs, and now they're not absorbing it, right? So these are things you want to try to figure out. Again, try to figure out their alcohol intake. Again, sometimes you have to multiply by 2 to actually get an accurate estimate. Depends on your patient. Ask about kind of dentition issues, if any. Ask about any kind of or what you end up finding is, again, more prescription drugs, more over-the-counter drugs they're taking, more likely are to see some interactions with their dietary intakes. You've got to be careful with that. And then also check for their weight. If they're especially at a disease state where they're more likely to put on weight, like CHF or something, like how are they trending that? If it's going down, that could be indicative of poor nutrition, things like that. And then just check for their ability to even physically do any of this stuff, essentially. Now, as far as looking at laboratory testing for assessing your patients, there's several labs we can do. However, you don't want to get every single lab out there under the sun, but let's look at a few. I'm sure you've covered most of these in Clin Lab already, so we'll kind of go over these real briefly. But let's see, CMP, which stands for Good Complete Metabolic Panel. What does that tell us? Besides a lot of stuff. Electrolytes, those are good, right? What kind of electrolytes? Sodium, chloride, potassium, magnesium. Yeah, so usually with a Chem 7 or like a basic metabolic, mag and phos are not going to be included on there, but you would get those most likely in a CMP. You're measuring that. What else does CMP tell us? Glucose, good. Creatinine, BUN, right? So good determinants of renal function are going to be on there as well. Anything else? Potentially albumin. I'm not sure if I see that one. Yeah, I guess you would see that potentially. You also see liver enzyme tests, right? So you see that ALT, AST. Those are usually included on a CMP. You might not get on a basic metabolic sort of panel there. But again, they call it complete because you kind of get a good picture of kind of everything that's going on from those circumstances there. Checking their serum cholesterol, their lipid panel, because again, having too high lipids, what could that predispose us to? Yeah, heart disease, essentially. Right. So again, these are things we're monitoring for, seeing, especially if they're on medications for that, how are those levels coming down? How about hemoglobin A1C? What does it tell us? Yeah, average blood sugar over the past 3 months. It could be important if you have a diabetic patient. CBC can be important. If they're not getting enough iron in their diet, what could that show?
Anemias.
Right, you can see anemias that can pop up on there, so that's good to look for. White blood cell counts can tell us about infection that might be happening. B12 levels that we mentioned as well with anemias can be important. And then urinalysis can tell us a lot as well. So again, if they're having any issues there. Right, so again, these are typical laboratory tests you would do to kind of assess your elderly patient. Again, the big ones I harp on a lot, at least for medications, are going to be liver function, renal function, electrolytes, because again, this kind of very direct effects on the medications that they're taking, right? And so when I say polypharmacy, anyone know what that means? Yeah, it's taking a lot of different medications, usually 5 or more regular medications. Now, why might people be on more medications as time goes on? They get more disease states.
I was thinking like sometimes you have to manage the side effects of the drugs they're taking.
Yeah, absolutely. They try to manage side effects of one drug with another drug. Absolutely. Usually, if you look at things like evidence-based guidelines, you typically find that they tend to add more drugs on as time goes on. So, for instance, if I have a patient who has, say, previous MI and myocardial infarction that led them to develop CHF, the list of drugs that are recommended by the guidelines are going to be they're going to be on an ACE inhibitor. They're going to be, you don't have to know this specifically. I'm just going to give you an example. They're on an ACE inhibitor. They're going to be on a beta blocker. They might be on an aldosterone antagonist. They're going to be on aspirin. They might be on a diuretic. They might be on digoxin. You see how this list starts to expand out. And again, that all may be recommended by the guidelines. May all be appropriate. However, it's going to add up pretty quickly. Now, if you had someone who had diabetes on top of that, guess what? Now you got metformin. Now you're going to have, maybe some like glipizide, and then, it just snowballs very quickly, as you'll see. Yes, ma'am. Right. This does not include the supplements, which is why it's very important to ask that question, because you can say, well, what drugs do you take? And they'll probably tell you if a prescription medication they take, but then you ask, well, what about anything you get without a prescription? And how you ask the question can be really important, because they may say, okay, well, I also take Tylenol, or I also take ibuprofen, and they have to ask, well, okay, specifically herbal supplements or dietary supplements, and they may give you even more information at that point. So again, if you don't ask, you don't really know if you have the full picture or not, right? Anyway, people tend to be on more drugs, especially hospital admissions. People typically are going to be on more meds on discharge than they were when they actually came into the hospital in the first place. So again, imagine a patient with osteoporosis, osteoarthritis, type 2 diabetes, hypertension, COPD. They might be on 12 different medications 5 different times a day. Now, I can't even take a multivitamin 1 time a day regularly. Can you imagine how hard it would be for someone to be on 12 different medications 5 times a day? Very, very difficult. What do you call that when patients are not taking their meds as they should? Yeah, not compliant, right? So again, and oftentimes, like, I can't blame them in a lot of cases, because again, their regimens are so difficult. It's like I couldn't even keep up with that sort of thing. So again, you have to kind of take that into account. And I mentioned hospitalizations are a big reason why people start new meds when they're discharged rather than being on fewer. Because again, as an admitting person, and you're looking at their home medication list, you're probably going to be pretty hesitant to discontinue anything else that other people will prescribe. You're just going to be like, well, I might just add on 1 or 2 things, and then their primary care person will figure that out, right? But you as a primary care person, if that's your role, you need to be the one that kind of takes charge on that and say, okay, well, let's stop the madness here. Let's go ahead and discontinue this drug, this drug, this drug, and then maybe you'll fix all their issues, right? So it just depends. Consequences. What is the problem with having polypharmacy? What can be some issues that develop from that? More side effects, right? More chances for drug interactions. A big thing we run into with geriatric patients is, and again, remember things like orthostatic hypotension. Remember, their baroreceptor reflex isn't quite so good as it used to be when they're younger. They're very likely to have falls, likely to have altered mental status, syncopal episodes, and a lot of medications can influence that as well, right? So for instance, if I put a patient who has issues with orthostatic hypotension, right, so they get up and they feel dizzy, now I put them on an antihypertensive that's lowering their blood pressure, is that going to worsen that? Absolutely, they're more likely to develop falls, right? They fall, break a hip, guess what? Now they're in even worse trouble than they were. So that can be a big issue. Decreased compliance is also going to be another problem you run into quite frequently, either due to mental decline that prevents them from being compliant, lack of resources to actually get the medications, etc. There could be any myriad number of reasons. So decreased compliance typically is going to be related to things like complex dosing schedules, multiple medications. I'll never forget this one lady when I was on rotations in a community pharmacy, and this lady came up and she was blind as a bat, couldn't see anything. She must have been on like 15 different medications. She was coming and getting them all refilled at the same time, and I was like, how do you know which medication you're taking? How do you know this is the metoprolol and this is the aspirin? And she was like, oh, I got the system. And she was taking all the old caps off of the old medications and putting them onto the new bottles, and she had like, this one has a giant triangle, like a red triangle. And she knew that was her metoprolol. This one has a big orange star on it, and she knew that was her aspirin. And I was like, do you actually know all these? And I quizzed her on it, and she, I mean, sharp as a tack, knew every single one of them. However, not all patients are going to be like that. Not all of them have that same sort of mental faculties associated with them. But anyway, economics, obviously, they can either not pick up the med at all, or potentially if they're skipping doses to be more economical, you may think, well, this drug is not working as it should, even though they say they're being compliant, because again, patients lie to you occasionally. they may think it's not working well enough, and you try to increase the dose, and then maybe that predisposes them to side effects, right? Mentioned mental decline. You know, if you're taking a med 3 times a day, I can't tell you how many phone calls I got at the poison center where it'd be like, oh, I thought I took this medication, but then I took it an hour later and didn't realize it was already taking it, right? So now I have a double dose of that. For some drugs, not a problem. For some drugs, that's a big issue, They can't swallow appropriately. What do you call that? Any term for that? A dysphagia. That dysphagia can be an issue, especially with like stroke patients and whatnot. You may have to switch them over to liquid medications potentially. If you're trying to bring someone in on the inpatient side of things, especially if they've had a lot of sticks over time, those veins tend to get fibrous tissue, scar tissue over it. Getting IVs placed can be very difficult. It's maybe harder to get an IV dose in. It's just patient willingness to adhere to treatment. It's one of those things where if the patient doesn't want to adhere to it, they're like, I don't feel that much better, and then I'm only going to be alive for another couple of years anyway. What's the point of doing it, right? That can be a common sentiment you run into. So going into that, we talk about end of life being usually 6 months or so for patients to live, and so you need to really kind of prioritize when you're dealing with older patients what the game plan is essentially, right? So again, you have to think: is my goal to increase the quantity of life or increase the quality of life? And so my background obviously is in toxicology, so people are trying to kill themselves, and I'm trying to keep them from being successful. My wife, on the other hand, she did her residency in pain management, especially at the VA, doing a lot of these older guys, and she's like, let's give them more morphine. Let's just keep giving them more, so at least they're comfortable, right? And so I think we're a good combination, because she gives them the drugs and I reverse it. But anyway, that's one of those things where those are older guys, they're not gonna make it through this bout of cancer. They're not gonna make it through whatever happens to be. And so the main thing is to increase that quality of life. Whatever time they have left, make them as comfortable as you can. And what do you call that? Hospice care, palliative care is another term we're gonna hear with that. And usually in the earlier stages of life, as treatment goes on, you're looking at life extension, trying to make them alive, keep them alive as long as you can. But at a certain point, you're going to be moving over to palliative treatment, where you're just trying to make them feel more comfortable, trying to make sure that the manifestations of their disease are not impacting their quality of life, or at least minimize as best you can. And then afterwards, obviously, after a patient passes away, then looking at family services as well to try to make sure they're being well taken care of. Additionally, because again, caregivers of chronically ill patients, they take a big hit as well from a psychological standpoint. It's important to consider them as well. Okay, so looking at kind of normal physiologic changes that occur in the elderly, what do you think happens with the cardiac side of things? Blood pressure probably up or down? Probably goes up, right? They're probably going to become more hypertensive. You're going to find the left ventricle tends to remodel over time to become less efficient. You're going to find that's where CHF kind of comes about in a lot of cases. You have like a reduced sort of heart rate, maybe due to that increase in afterload potentially. The kidneys are one of the big things we're into, at least from a drug standpoint. Typically, renal function is going to do what? It's going to decrease over time, right? Everything is going to start breaking down, right? It felt, especially like when the day I turned 30, I felt like everything just started hurting. I was like, what the heck's going on? Can't trust your GI tract anymore. No, I'm just kidding. But especially as they get older, as they get above 60, 70, 80, this is where things, especially like the renal function, is going to really take a big hit. So that decrease in GFR, that glomerular filtration rate, is important, because if if they're not processing things with the kidneys as well, what do I need to do with their drugs? I mean, decrease the dose, or maybe I'm giving them less frequently. Like, there's big changes you have to make, and you need to make sure you're looking at that regimen, because oftentimes what you'll run into is patients will start off on a drug, say, when they're 80, and the dose was fine at that point, but then now they're 90, and no one's ever gone back and looked at that dose again. They've just been on for 10 years, and no one's checked it. And now the levels are way too high because they're not clearing as well as they used to. And that's a common occurrence, a common reason why patients may come in due to medication issues. Also, they're going to have a harder time maintaining good acid-base balance. That could be another thing where they may be more likely to become acidotic potentially. It can be a problem. And again, looking here, even at 30, like I said, everything starts to going downhill. So even maximal breathing capacity, already taking a hit here. So I'm huffing and puffing up here, trying to talk to you guys. Certainly GFR, especially, and again, some patients are going to be much more accelerated than this than others. It just depends on their disease states, depends on, do they have hypertension, do they have diabetes, all of these things can have a big role here. But again, everything is going to be declining to some degree. Okay, so normal age-related changes, at least to the kinetics of things. So looking at the gastrointestinal tract, you may find decreased hydrochloric acid production, decreased pepsin production, but the one thing you may run into is like decreased gastric emptying, right? So things may not be processing through the GI tract as quickly as it should, and that can delay absorption potentially, right? Typically, you're going to find drugs still get absorbed just as well as they would in a younger patient. It just may take longer for it to occur. So you may find that they don't get the same kind of peak levels as you might in a different patient. But the thing to consider is the liver, especially if they have things like CHF, they have edema, typically you're going to have decreased liver blood flow. And we mentioned less blood flow going to the liver means what for drug metabolism? It's going to slow down, right? Because if it never makes it to the enzymes, it can't be metabolized essentially. Okay, so you're typically going to see that's going to be an issue, especially with like cirrhotic patients or patients with pretty significant liver dysfunction. It can be an issue. Yes, sir.
So would you take that into consideration regarding like the first pass effect and whether to like, where you said noting like those little capsules that surround it to like bypass that whole liver effect and whatnot?
Yeah, so in that case, when you're considering like first pass effect, normally when you're looking at a drug reference and you're looking at dosing, usually there's a section for like normal dosing for like normal healthy adults, or I guess disease adults potentially, but just typically adults without organ dysfunction. Then you're looking at renal dosing. So they take into account if your renal function has declined to this amount, you're going to change this dose this way. And then there's usually a section for liver dysfunction as well, right? So we'll say, okay, well, if you're, I'm not going to get into the different staging of it, but this Child-Pugh score, basically telling you the dysfunction of the liver, the more advanced it is to say, okay, reduce this dose by 50% or something. So that way you take into account the first pass changes that may occur there. Yep. So as I mentioned, absorption doesn't change dramatically. However, the drug interactions are going to be a big problem here. So, for instance, if I have someone who has issues where they're taking medications, they're going to bind up other ones. So, for instance, I'm starting, you have a patient who's on, you prescribe an antibiotic for, say, a UTI, and then they're on, say, Tums that are going to bind up with that. Well, now the drug can't be absorbed, and so that's going to be a problem. They're not going to clear that infection, and even though they're taking it like they should, they're just having that drug interaction occurring there, right? Some patients may have like impaired gastric emptying, especially diabetics. Anyone know what that's called? Gastroparesis. Yeah, so you may have gastroparesis with those patients. It can slow down absorption time. But typically, absorption still should occur as long as there's no interactions preventing it from occurring. Drug distribution also is going to take a big hit here. So typically what you're going to find is that patients, as they get older, typically lose lean body mass, right? Typically losing muscle mass over time. However, they're also going to have a reduced body water, right? So what type of drugs do you think this might affect? Hydrophilic or hydrophobic? Hydrophilic, right? Because again, if there's less water for the drug to partition into, that can affect the volume of distribution, right? So looking between, say, like a 20 to 30-year-old versus a 60 to 80-year-old, you can see the body water percentage tends to go down. You're going to see lean body mass tends to go down as far as percentage goes, but the body fat typically is going to go up. So then that might affect the volume distribution for lipophilic drugs. You may find that has more tissue to partition into. Now they're going to be distributing out farther in those cases, right? So that can be one change you see there. Things like serum albumin, we mentioned this is really important for drug binding. So if that goes down, maybe you have higher free fractions of drugs to interact with the receptor. That can be an issue. And then looking at hepatic blood flow, kidney blood flow typically can go down over time as well, which can impair that function additionally, right? Okay, so I mentioned protein binding. Decreases in serum albumin could be related to nutritional changes. It could be dependent on several disease states as well, but it typically goes down. Can certainly affect weak acids that may bind to it, right? So again, change that free fraction. But other proteins may actually be increased in some cases, but clinically this becomes less relevant with alpha-1 glycoprotein. Just know, but anytime you're changing the percentage or the values of those proteins there, you're changing the free fraction to how much of it's available to interact with the receptor. Okay, this one's really, really important for drug clearance. Going to be the kidney changes that occur here, right? So again, reduced renal function should be assumed with elderly patients. And in fact, what you may find is that we mentioned muscle mass in these older patients is doing what? Muscle mass is typically decreasing, right? Maybe you have like a bodybuilding grandpa or something like that, but typically muscle mass is decreasing. And so we mentioned, where does serum creatinine come from? From the muscle breakdown, right? So again, you should be, you're going to have cases where you're going to have elderly patients who are having relatively low serum creatinines. You may think their renal function looks really good, but really they didn't have the muscle mass to actually produce the creatinine in the first place. That makes sense? So what I find is, I'll have a patient, I mentioned what's kind of like a normal serum creatinine. Remember, like 0.6 to 1.2, probably for an adult would probably be considered okay. And I have, a 90-year-old lady who is, a little tiny old lady, probably, 80 pounds sopping wet, has no muscle mass whatsoever, and she's got a creatinine of 0.5. I'm like, man, she's got really good kidney function. Probably not the case. Probably she just doesn't have enough muscle mass to make the creatinine. Usually what I'll end up doing, and this is just something I do, is I will round up to at least 1 in order to make sure I get a little bit better estimation. So that way I'm not overestimating what her renal function is. You guys remember the equation we used to calculate creatinine clearance? We talked about the Cockcroft-Gault equation. Remember how age is factored into that, serum creatinine is factored into that. So I kind of fudged the creatinine a little bit to try to make it so that it's probably closer to what it truly is. And again, it's always just kind of a surrogate number. It's all kind of a fudge factor to try to get an estimation there. But because of that, typically what will happen to the half-lives of these drugs if they're not being cleared through the kidneys? Going to be longer, right? If I can't clear the drug is going to stick around for longer, the half-life should increase, right? And so that means I can also increase the risk for having toxic concentrations as the drug levels build up in the body. That can be an issue there. And then also it can be affected by hydration status, right? So if I'm very hypovolemic, we mentioned where does the body want to send blood to? Heart and the head, right? So if the kidneys are taking a back seat to that because I'm dehydrated, that can also dramatically affect renal function as well. Because again, if the blood's not getting there, it's not going to be able to carry the drugs to the kidneys, right? So I mentioned that Cockcroft-Gault equation. We'll use this occasionally, but again, this may only be good for patients in certain age ranges. You find as they get older and older, maybe something like this MDRD equation. You won't have to calculate this specifically, but just remember what the values are going to have on what effect the values are going to have on the total creatinine clearance, essentially, right? So I mentioned if I have less serum creatinine, what happens to my creatinine clearance? Goes up, right? So I would assume they have better kidney function, but again, if they're not producing that creatinine in the first place, then I'm going to overestimate it, right? What if I had a patient who had say for instance, had a bilateral amputation? So they had very uncontrolled diabetes for a while. They had both their legs lopped off. What do you think that would do to creatinine clearance? That would falsely elevate, right? Because again, where do you make your creatinine at? In the muscle, and if I take off the legs, if I'm doing bilateral below the knee amputations, like that's a lot less muscle they have to produce that creatinine. I'm overestimating what their creatinine clearance is. And one of the things you'll know about diabetic patients is their kidneys oftentimes is one of the big organs that takes a hit there. So again, I know that diabetic patient is not going to have great kidney function, even though the creatinine looks okay, right? Could be due to these amputations here, right? So just something to consider. All right. Usually, as far as drug clearance goes, liver is going to be less affected than the kidneys to some extent. However, if I'm doing anything to decrease blood flow to the liver, that's going to decrease the amount of clearance we want to have there. So that's definitely what we're going to see. Looking at the actual enzymes that are being expressed, remember what's our most important enzyme system in the livers for drug metabolism? Cytochrome P450, right? Cytochrome P450. Those typically don't change in numbers quite dramatically. However, if we have things like inducers, if we have inhibitors, that can have some major effects. Again, drug interactions are going to be one of the big things you see within the liver specifically. Okay, so looking at pharmacodynamic changes, those are all kinetic changes we're just looking at. Are geriatric patients more sensitive, so to speak? Certainly, probably a lot of the issues you run into are going to be more the kinetic side of things. So, for instance, if my drug levels are building up, I'm giving a standard dose to a patient, but they can't clear it, and the liver levels are going up. They may seem like they're more sensitive when really it's just the levels are just too high for them, right? I could have adjusted the dose and that could have fixed it. That could be one thing. They also are going to have less than sort of homeostatic sort of responses there. So I mentioned like the orthostatic hypotension tends to get worse, especially when you're adding on these medications, and that could change how much the patient's really kind of how much of intensity they're actually experiencing there. So as I mentioned, your cardiac output is going to be impaired here. Temperature regulation, they maybe have a harder time. I always hated like going over to my grandparents' house because usually old people feel hot or cold. Usually feel pretty cold, so I'd always go over there. It's like set to like 82, and I'm just like sweating like a pig. And basically, it's just one of those things where they have a hard time regulating their temperature. Now my parents are starting to do it, and I'm just like, oh no, they're getting old, it's getting bad. Fasting blood glucose, you expect to go up or down? Probably going to go up over time, right? They develop insulin resistance as they get more and more kind of chronic diseases. You're going to find that typically glucose is going to ride higher, typically. But and again, drugs can affect that pretty dramatically, as we'll see specific examples in the next class. So let's look at some examples of drugs that might be not great for our geriatric patients to affect them. So let's say, for instance, we're talking about sedative hypnotic agents. You could probably classify my lectures as a sedative hypnotic agent. So what would that be doing to you? Putting you to sleep, right? It's knocking you out. You can find that for a lot of these drugs, in fact, these are going to include things like benzodiazepines. Anyone ever heard of like Xanax or Versed or Valium? That's a group of drugs that are sometimes used for anxiety, sometimes used for sleep. You can find their half-lives can be extended dramatically, 50 to 150% potentially. And not only that, but some of these drugs have what we call active metabolites. So you think everything goes through the liver, should be metabolized into inactive products. However, some drugs have active metabolites that still work just as well as the parent drug did. So because of that, they have active metabolites that stick around for a lot longer, and it makes it so that they are much more likely to have ataxia, much more likely to have falls, altered mental status. And one of the biggest things, especially working in the ER, patients come in for an altered mental status, like that's the first thing you have to figure out what's going on. Okay, is it their glucose? No. Is it their oxygen? No. Okay, is it meds? Like, is it something that's affecting them from that standpoint? Because again, those are some of the common things you're going to run into, affecting their mental status. Frequently what we'll do is try to shoot for drugs that have no active metabolites. We're going to shoot for drugs that have relatively short half-lives. So that way, even if they're a little bit longer in these older patients, they can still clear them within some relative decent amount of time, right? Looking at analgesics, especially at opioids, patients tend to be susceptible to the respiratory depressive effects, especially when they're mixing and matching some of these other medications. And they can also have accumulation of those active metabolites. There's anyone ever heard of the drug Darvocet before? Or Darvon. It was the one that actually got taken off the market probably when I was in fellowship, so it must have been like 2011, 2012, and it actually got taken off the market because these elderly patients would take it for pain, and they would actually build up active metabolites of it, and in fact actually found that it caused dysrhythmias. It actually took that off the market completely because it was such a danger for these older patients, and so many people were taking it pretty regularly. Antipsychotics and antidepressants, probably something you think a lot of your professors might need, but can be probably pretty problematic. So for instance, lithium is a big deal because lithium is entirely dependent on renal function in order to get eliminated. So if you have any kind of hit to renal function, either through just natural decline or maybe dehydration, they're going to hold on to those levels, and you can have very significant amounts of it being held onto the body, and you can see things like seizures, altered mental status can be very, very bad. Also, things like diuretics can affect this, and so it can be very problematic for these patients. Other things like antidepressants, a lot of our older agents tend to cause a lot of sedation, tend to cause a lot of falls. So luckily now we have some newer drugs, and in some cases newer drugs are a lot better and safer. And this is where things like the SSRIs or the selective serotonin reuptake inhibitors like Prozac and Zoloft and things like that can be very useful and much more safe for our patients. So sometimes we change whole groups of drugs that we're using because we know that these ones are going to be safer. It doesn't matter if they're more effective or not. It really just matters if they're that much safer for the patient, right? Cardiovascular agents, obviously antihypertensives are going to increase that risk for orthostatic hypotension. Patients may develop electrolyte imbalances with diuretics. They do that. That can predispose to things like arrhythmias, altered mental status, all kinds of things here. And then the antiarrhythmics themselves, these patients have pretty poor hemodynamic reserve, so much more likely to develop things like hypotension. And then because of their electrolyte imbalances, they're much more likely to develop arrhythmias, especially with these drugs here. One of the things you'll learn with both anti-epileptics or anti-seizure drugs and then with the anti-arrhythmic drugs, so treating arrhythmias, is that not only do they treat those conditions, they also can cause those conditions as well, especially if the levels get too high. So any antiarrhythmic can cause potentially an arrhythmia, especially if their potassium's off, their magnesium's off, calcium, any of that stuff, right? So basically, with your adverse drug reactions, you expect the increased number of drugs they have is going to increase the number of adverse drug reactions they're likely to experience. Say for instance, with a single medication, may only be 10%, but by the time you get up to 10 medications, it can be nearly 100% likely they're going to develop some sort of side effect. The question is, does the patient even understand that they're experiencing a side effect? They may just think, oh, I'm just getting older. This is just how things are now. And really, that's why education is so important. Anytime you do a new medication, explain what the side effects are going to be, explain so they know what to look out for, what's normal, what's not normal, and what they should be coming back to you for, essentially. And then also adding in things like OTC and herbal medications. I don't have a particularly strong stance against or for herbal medications. Some of them have very strong effects. Some of them don't work quite so well. However, these can have very real drug interactions and can potentially cause some pretty significant effects for your patient. So has anyone ever heard of the drug called St. John's wort? What do we use that for? For depression. It's actually pretty okay for mild depression. It has some decent effects to it. However, though, if I mix it with an antidepressant, right? So if I don't tell my patient who I prescribe Zoloft to, hey, this interacts with other things like St. John's wort, and they go ahead and just start taking it because they have depression, I'm going to take everything I can for it. That can lead to some very significant interactions. There's one called serotonin syndrome, which we'll talk about in pharma. It can be potentially deadly, right? So these are things you have to be aware of, and always ask, hey, are you taking anything over the counter, anything herbal, because you need to get the full picture, essentially. All right. As far as prescriber errors go, always make sure you're taking into account their age, look at their organ function. If they haven't had a creatinine done, they haven't had the renal function checked in 5 years, guess what? Just go ahead and get it, check it out, see what it is, because it's probably changed, right? Issues can happen from patient compliance errors. So if they don't understand how they're supposed to be taking these medications and maybe they're taking them inappropriately, that can be one thing. Or if they're seeing multiple providers, I already said that was a big issue. You guys ever heard of like a brown bag event? It's something we did in pharmacy school where basically there's like a nursing home we'd all go out to, and they basically bring all the residents out and they bring out these little brown bags that had all their medications in it. You see stuff from like the 1980s in there, and you see stuff that they'd been told not to take, so 10 years ago, and you find all these different medications. Our goal is to go in and try to do a full medication reconciliation, figure out what they should be on, what's expired, what's not, and go through. And it's amazing to see how many different providers they'd had all these new medications from, and no one's communicating with one another. So that's why you see all these interactions develop here. Some cases, even patients may not understand what actually is a drug or not. So anyone ever heard of a BC powders or a goodies powder? Not a lot of people. A lot of people from Florida probably heard of this, but for whatever reason, people north of us, the northerners, typically have not heard of a lot of these. Anyone know what is in BC powders or goodies? It's actually aspirin. So, so these are basically these little sachets, these wax papers full of powdered aspirin. Dip it in their drink, and they go ahead and take it. Well, they may not understand it's actually a pretty potent drug. It's aspirin. So if you had this one patient, I'll never forget, he would take aspirin every day for his heart, which is a pretty low dose. We take a tablet of aspirin, but then every time he had chest pain, someone told him to go ahead and take a goodies powder. This guy had very uncontrolled angina, and so every time, a couple times a day, he would just start taking these goodies powders over and over and over again. And then eventually, the chest pain wasn't going away. And he's like, okay, well, I better call 911. So he calls 911. EMS shows up, and they're like, hey, have you taken any aspirin today? He's like, oh, I took like a little baby aspirin this morning. They're okay. Let me give you some more aspirin. He gets into the ER, and EMS, they're busy guys. Like, they ended up leaving before they gave a report out to the doc. So the resident at the time didn't know that patient already got an aspirin, and asked the guy, hey, did you take any aspirin today? Oh, I just took a baby aspirin this morning. Okay, here's some more aspirin. All of a sudden, he's like huffing and puffing, he's sweating, and he's getting red, and they're like, what the heck's going on with those guys? And they ruled out an MI, so that's not it. And he's complaining there's ringing in his ears, his tinnitus, and once we got the full history, you should probably check an aspirin level. And sure enough, it was like, sky high. Ended up having to treat him for that. So he came in for chest pain and ended up developing aspirin toxicity, and got a whole other set of treatment for that. So again, ask them about this sort of stuff, because again, they may not understand its medication. Especially ask about family and home remedies and things like that. They have family from other countries. They're coming over. They may bring home remedies with them. They could be all sort. Who knows what it is? It could have all sorts of things, whether it's herbal or otherwise. It could have some big effects there. Okay, so again, here's some questions you can always use to try to get a good structured sort of history on their meds they're taking here. So obviously, are you taking the drug as prescribed? And how can you assess whether or not a patient actually knows what you've described to them, if they can actually they actually know what they're supposed to do? You guys heard the teach back method? So basically, you tell them, okay, I want you to take this tablet twice a day. Now tell me how you're going to take that. He said, okay, I'm going to take it in the morning, I'm taking it in the afternoon. That shows you they understand how they're supposed to take it. If there is any disconnect there, you can correct it right then, okay? Because again, it's one thing to just sit there and babble at people for 4 hours straight and assume you get everything I say. However, if I can stop and ask you guys a few questions every once in a while, maybe I can assess whether things are how they're going. Usually the number of blank stares I'm getting can give you a good idea too. Just like your patients, they're staring at you and you're just like, something's not, there's nothing connecting there, right? So again, you have to do that teach back method to make sure they kind of get it, right? So ask about side effects. If they may not know what a side effect is for that particular drug, so explain, okay, have you experienced any of this? Have you noticed you get extra dizzy when you stand up? Things like that. If you're deviating from the medication, why? If they're going to own up to it, say ask them why they're not taking it like they should. Again, any other medications not on the list? Old people, they like to be thrifty. So a lot of them are on fixed incomes, and so they may take medication from their buddies, right, or their other family members, or something like oh yeah, I had a UTI last year. I got a bunch of Cipro left over. You want to have some of mine? Okay, here you go. Now, they're on a medication that has not been prescribed to them, and you don't know that unless you ask the right questions, right? Any homeopathic medication? When I say homeopathic, what does that mean? It's very dilute medication, like thousands and thousands of times. Basically, you get like 1 iota of a molecule of drug per every liter of it or something. It's very, very dilute meds. But you still have to ask. You still have to find out if they're taking any of those. But there's herbal medications, there's vitamins. I don't take a strong stance against herbal supplements. Homeopathic, I'm probably, if it works for you, I get placebo effect is a very strong effect, I will say. That is true, actually. Placebo effect is a big deal. But anywho, any meds that belong to family members or friends, as I mentioned, any drugs on demand, maybe they're getting meds from other places, maybe not in the U.S. I've not experienced this myself, but I've heard accounts from patients where they can just go online to a random website and they answer a couple of questions, they get any med they want, right? Just show it up at their door. Pretty scary, especially if they're, because I'm sure a very highly qualified licensed physician is reviewing every single one of those scripts before it goes out. That's probably not happening, right? So,
Like Teledot?
Hmm?
Like Teledot? teledoc?
Not like telehealth, like that's actually a legitimate sort of thing. Like, but this is more like going on to like freeviagra.ru and then being like, yeah, I don't take anything else. Okay, great. Here, send me my Viagra. Like I said, not me personally, but I've experienced patients doing this before, right? Anyway, actually get sponsored by that website. I'm just kidding. But yeah, ask about drugs are no longer being prescribed. Again, these older patients are thrifty. They don't want to get rid of drugs even after they've been, they're not supposed to take them anymore. So they'll hold on to them for years and years and years. So you can find meds from the 80s in some cases. And then when's the last time you checked the expiration dates? Now, I will tell you most expiration dates on meds are pretty bogus for the most part. You can find, actually there's an interesting study they did where there's a pharmacy that was closing, and it was like, it used to be this really old-timey pharmacy. It used to have stuff from like the 20s basically. And so they went through and they had found this old cache of like all these medications and stuff, and they went through and they actually checked the potency to see how much was actually left of the drugs after all these decades, and actually found that almost every single one of them was within 10% of the actual stated dose, except for like aspirin and like phenobarb. Everything else was totally fine. So especially at tablets, things like that, check the expiration dates, but keep in mind, we like them to use non-expired meds, but just have them checked. Anyway, are you taking medication independently? If not, is anyone helping them out? So especially if they're having like CNS decline, they're not able to remember things effectively. Like, who's kind of helping them out? Are they using any sort of dosage systems? I'm sure you guys are familiar with those boxes where they'll have like Monday morning, Monday afternoon, Monday evening, Tuesday morning. Those little pill minders helps them out. I hate those things because from the tox standpoint, kids get into them and then they just pop up with a bunch of them, and then you don't know which pills are where. You have no idea how many are missing. It's a problem for me from a tox standpoint, but it's helpful for helping those elderly patients to remember stuff. Ask about things like their inhalation therapy. Have them demonstrate how they're using their inhalers to see if it's even effective. Remember that GIF I showed earlier a couple of classes ago? The lady was like, kind of puffing it on their neck like it was perfume. Like, that stuff has happened before, right? That's probably come from a real life story. Eye drops, any difficulties with those? We'll talk about those in Pharm 1. And then, if you forget to take your medication, what do? For some meds, it's appropriate. Go ahead and take it as soon as you can. Some meds you would double up the next day. It just depends, but they need to be able to explain that to you, right? Okay. Here's some examples of those pill minders. There's really other advanced ones now. There's plenty of apps that can remind you when to take meds and all sorts of things to help your patients out. Phone call services will just call you up when you need to take a med, all kinds of things. Okay. So just remember, as far as like practical applications of things, remember medication expense, because it does not matter how great of a med you're going to give this patient, but if they cannot afford it, they're not going to take it, right? So for instance, you may have this new arthritis med. It was great because this drug rep came by. They gave you the most awesome dinner, and they said this drug is the absolute best. And you're like, this sounds great. It sounds like it's the best. Okay, I'm going to go ahead and prescribe it for everyone. $1,000 for a month's worth versus you can just use aspirin. It's $5 for a month's worth, or you can use ibuprofen or something, right? Sometimes the cheaper stuff is okay. Like, you can get away with that. There might be specific instances where that newer one is better. That's fine, but think about what the patient can afford. Okay, especially with insurance being so difficult for some patients, you're going to understand based on who you work with most commonly, like what their insurance covers, what's on formulary, or what's not, and it's stuff you have to take into account. Also, if you go on the website for the class, I also listed things like the Publix free drug list or like the Walmart $4 list. Like, those are good meds to get familiar with, because again, most of your patients are going to be, not billionaires. They're going to be, needing to consider all their dollars and cents. And so knowing that list of drugs, getting familiar with those are good, because you can just easily prescribe this. Hey, $4 for $30, 30 days worth of lisinopril or something, right? It's easy for anyone to afford in some circumstances, right? If you can try to get meds with the same dosing intervals, so that way they're not taking one thing 3 times a day and one thing twice a day. If you can keep it all the same, that's going to be better. Watch out for that intelligent non-compliance. Anyone know what that means? Yeah, so they're basically saying, well, maybe this is too expensive. I'm going to take it every other day instead of every day, or they're deciding, oh yeah, of course I'm taking that, but maybe a side effect is preventing them from is intolerable, and they say, okay, I'm still taking it even though they're really not, because the side effect was so bad. Like, that's stuff that you need to encourage. Good open conversations with them, like no judgment with these patients. If they're not taking it, just have them tell you, so that way you can give them something that maybe is going to be better for them overall. Then consider, can the patient physically take the drug? For instance, some of the medications we use for rheumatoid arthritis are actually injectable products. They come in these little pens, some are like an insulin pen or something, where they have to stick themselves and they can inject the drug. However, if they have rheumatoid arthritis, their joints might be no good, right? They may not be able to have the dexterity to actually administer the medication. Those are good questions to ask, right? So, any questions on the Jerry's? The Jerry's of the world. You're going to treat a lot of them in your days, I might imagine. Nothing? Okay, I think I'll go ahead and let you guys go now. So enjoy your 5 minutes, and I will see you next time.